Well, this is my second go around to do endocrine. It was my fault. I forgot to push the red button, but I pushed the red button this time. So let's get on with the endocrine metabolic disorders, and we may actually pick up another PowerPoint in here. I'll have to see how long this one is, how long it takes. Oops. Endocrine. Alright, endocrine and metabolic disorders that are related to pregnancy or affects pregnancy. Our most common endocrine disorder associated with pregnancy is diabetes. And you have pregestational diabetes, which means they have insulin-dependent diabetics before they became pregnant, or you have gestational diabetes, which can be handled either by diet and exercise alone or with insulin and metformin. So the key to any pregnancy, to an optional pregnancy with anyone that has diabetes, especially the pregestational diabetes, is have a strict glucose control before and during pregnancy. And the reason it's so key with the pregestational diabetics is that when they become pregnant, they're already having issues with their sugars. So if they can keep them in control, there's a less possibility of developing congenital anomalies. Out of control pregestational diabetes, their babies have a high risk for having congenital abnormalities plus cardiac issues as well. During their pregnancy, hypoglycemia occurs in that first 3 months, in that first trimester. If you'll recall, in normal labor and delivery, your glucose will drop because of the sugars that are being used to go to fetal development. So an insulin-dependent pregestational diabetic will have to decrease her insulin during this first trimester because it's going to, her sugar is going to be being used for the baby and she won't need as much insulin. So her insulin needs will drop. Then when she gets in that second to third trimester, this is when the placenta starts producing insulinase hormones that are going to block mom's insulin from using the sugars so that the baby gets more sugar. So during the second and the third trimester, her needs for insulin are going to increase. So we have to keep a really tight control on that. Babies of pregestational diabetics usually are small for gestational age, whereas babies with moms who have gestational diabetes are more prone to have macrosomia or be a large baby. They aren't as much, they're not at risk for the congenital anomalies because they don't have gestational diabetes in that first trimester. It becomes apparent in about 24 to 26 weeks when we start testing to see if they have it. Once that placenta is delivered, the insulin needs usually will return back to normal in a pregestational diabetic within a few days. But the first 24 hours are very important because mom's insulin needs, again, will be lower because she is recovering from having the baby and there's no longer any insulinase being produced to keep the insulin blocked. So she has to be really monitored closely for those first 24 hours for hypoglycemia. If pre-gestational moms decide to breastfeed, it will help keep their insulin needs lower for around 6 to 9 months. Uncontrolled diabetes during pregnancy with a gestational mom leads to macrosomia. With a pre-gestational mom, it leads to congenital anomalies and small for gestational age babies. Reason that babies are smaller, maybe IUGR baby as well, is because mom has the vascular constriction that diabetes causes, and the placenta does not get as much nutrients and blood flow as if they would if they were gestational diabetic, because gestational diabetes doesn't occur until they're 24 to 26 weeks. So we test them at 24 to 26 weeks. Glucose is not an issue till that second trimester. We've gone over that. Same intrapartum care as with the insulin-dependent diabetes. You have to watch their glucose. Usually, with a gestational diabetic, once that placenta is out and the insulinase is no longer being produced, their sugars drop down to normal and everything usually goes fine. Fasting blood sugar should be done the day after, the morning of the delivery, after she delivers. Should be done postpartum day 1. Okay, hyperemesis gravidarum. Some of you have written pathophysiologies on this. You should do well on hyperemesis gravidarum. Some of you have done gestational diabetes. You should do well on that. Hyperemesis gravidarum is when your pregnant patient is just severely affected by nausea and vomiting. There has to be at least a 10% weight loss for them to consider it hyperemesis gravidarum versus morning sickness. They have such an excessive nausea and vomiting and lack of being able to intake fluids that they actually become hypovolemic. So they have low blood pressure, they have increased pulse. Of course, their skin tartar is going to be bad, and electrolyte imbalances are going to be seen in these hyperemesis gravidarum. These girls are really sick. We should be testing for ketones in the urine, see if we have any ketonuria going on. Treatment for hyperemesis gravidarum is that the patient has to remain NPO until after the dehydration is resolved through IV fluids and at least 48 hours after vomiting has stopped. So even when she stops vomiting, we can't just start feeding her. We have to wait 48 hours after she stops vomiting to feed her. Corticosteroids are used as well as multivitamins, and usually what the doctors do they order 3 different IV fluids. One has electrolytes in it, one has vitamins in it, and one just has a hydration factor to it. So you are hanging 3 different fluids in tandem order, so you have to be very careful about your IV fluids. Of course, with anyone who's hypovolemic, you need to have accurate INO. She needs to have a daily weight to see when she stops losing weight, hopefully. Provide her a quiet, cool room so she doesn't get nauseated, and decrease those odors. And tell family members not to be bringing food in, even if she's hungry, if she's on that NPO status. Once we start getting her to where we can feed her after that 48 hours, we need to encourage her to eat frequent small meals during the day instead of eating 3 large meals. She needs to just eat small meals frequently throughout the day, and she needs to drink separately from her meals, because drinking a lot of fluids will cause her to be sick. Hyperthyroidism. People who have hyperthyroidism that get pregnant have an increased risk for preeclampsia because of the way that hyperthyroidism works. And Ms. Candler is going to go over this with you guys next week, so you'll know a little bit more about how it affects normal people that aren't pregnant. But we're going to cover it just in how it affects the pregnant woman. Primary treatment, of course, is PTU. And there is a side effect with this. A granulocytosis is a um, side effect that you really have to be diligently looking for. You know, a lot of times pregnant women come in, they got a sore throat and fever. You just think they have maybe a touch of the flu. But this is actually a side effect of the PTU, and we need to stop the medication and call the MD. We don't contraindicate breastfeeding with hyperthyroidism, but the medication that they take, the PTU, does cross through the breast milk, one of the few drugs that do, and so we really have to have the baby's thyroid checked to make sure that the medication is not causing the baby's normal thyroid to become hypothyroid. Then we have the hypothyroidism and the PKU. Hypothyroidism, moms used to be infertile, but since we've had the invent of levothyroxine, we've been able to get, our women have been able to get pregnant. Usually these women will have quite a bit of weight gain. They'll be fatigued, cold intolerance, and have constipation because their system is working so slow. If we don't treat it during pregnancy, uh, baby could be stillborn, she could develop preeclampsia, and she could develop abruptio placenta. And pretty much that's what I want you to know about hypothyroidism. PKU, phenylketonuria, is something we test for when we do the PKU, or the Guthrie test, when we do the heel sticks and get the blood draws. Fetuses may develop some neurological problems if mom doesn't comply with the diet. So if mom had PKU when she was born and she stayed on the PKU diet until she got till brain function, brain development growth stopped, which is usually in the preteens, early teens. Um, she may go off the PKU diet. A lot of people do that have PKU. They still have a lot of phenylalanine in their bloodstream that's not being utilized, but it doesn't do damage to their mental status like it does if you're having it while you're having brain development. So these women need to go back on their PKU diet before they become pregnant, because chances are their baby's going to be born with PKU. And if mom's having an excessive amount of PKU, then it's passing over the placenta, and the baby is developing a lot of high PKU and will be affected more severely with the neurological problems than if he was born and we were able to take care of the PKU by diet and getting rid of the PKU in the baby's diet. We don't encourage breastfeeding. In fact, we kind of discourage the breastfeeding because mom's breast milk has to be checked for PKU quite often, and the baby's phenylalanine levels have to be checked quite often to make sure that he's able to drink the breast milk, that there's not too much PKU or phenylalanine coming through the breast milk. And that was the end of that one. Pretty short. I think I'll go ahead and post it and then go to the other one.